So good afternoon, everybody. It is my great privilege to announce Dr. Indy Singh as our pulmonary grand round speaker. So for those of you who don't know, Indy was born in Malaysia. At 17 years old, he traveled to Ireland to attend med school and part of residency. He then moved to the US to complete internal medicine residency at the University of Pennsylvania, then went to New York to complete pulmonary and critical care fellowship at Cornell. After that, he went to Brigham and Women's for the Advanced Pulmonary Vascular Diseases Fellowship. We were lucky enough to recruit him here. And just some interesting facts, actually Ireland destroyed Indy's palate. He can no longer tolerate spicy food because of all the time he spent in Ireland. So he started here about 8 months after I did, and so there's a few of us who all started together and have developed a lot of camaraderie. But in his time here, Indy started actually right out of fellowship as the director of the Pulmonary Vascular Diseases program. And while here, he won his teaching award the first year he was here. He helped bring on level 3 CPET. We now have pulmonary thromboendarterectomy here, and a really advanced pulmonary vascular disease program that has developed extensively under Indy's leadership. And so without further ado, welcome Indy.
All right, thank you, Brian. So I'll be talking about the diagnostic and clinical utility of advanced hemodynamic assessment in patients with pulmonary hypertension and unexplained dyspnea, with a focus specifically on long COVID. These are my my financial disclosures. And so we'll first talk about the diagnostic utility of cardiopulmonary exercise testing in pulmonary hypertension and unexplained exertional intolerance, and what information that we can gather beyond conventional hemodynamics from standard clinically indicated right heart catheterization, and how we can integrate cardiopulmonary physiology with omics. So the current treatment paradigm of pulmonary hypertension focuses on tertiary prevention. So by the time we do a resting right heart on patients, they'll have an elevated pulmonary vascular resistance. A lot of times they're in functional class 3, if not 4, and they're often in this far end of this curve right now. So folks often come to us with established fixed pulmonary vascular remodeling. And so the idea is, can we identify patients on the left side of this curve right here, where they are dyspneic primarily with activity, or fatigue with activity, with mild or normal resting hemodynamics. And that's because exertional dyspnea represents not only the most common, but often the most debilitating symptom in patients with pulmonary arterial hypertension. And there are many different causes of dyspnea in patients with pulmonary hypertension. So you can have the central cardiac limitation. So you can have right ventricular dysfunction. You can have chronotropic incompetence. You can have skeletal muscle dysfunction. So increasingly now, pulmonary hypertension is being recognized as a systemic disease that extends beyond just the RV and pulmonary circulation. So a lot of patients have skeletal muscle myopathy. They have small vessel obliteration, and they have intrinsic mitochondrial dysfunction as well. And then, of course, they can have disorders of the pulmonary vasculature. And there are other factors as well. A lot of these folks have iron deficiency anemia because it's a pro-inflammatory phenotype, pulmonary hypertension, and that causes impaired gut absorption of iron, and as a result, they get iron deficient. So the dynamic exercise testing, it allows for integration of all these factors, right? It allows for integration of the heart, the lungs, and the skeletal muscle. It allows us to identify aberrant physiology that is otherwise not apparent on supine right heart testing. And for the because of that, it allows for potential for earlier diagnosis and possibly treatment. And hopefully then by identifying which is the cause of the exertional intolerance, you can then direct your treatment towards that very specific factor, allowing for more precise medical treatment. And so there are varying levels of cardiopulmonary exercise testing. You have the conventional non-invasive CPAP with a cyclorocometer. You have level 2 CPAP that incorporates a radial outline, and a level 3 setup, which we have here, where you incorporate both an A-line and a pulmonary arterial catheter. In our clinic, we perform submaximum CPAPs on all of our patients. We do this as opposed to a 6-minute walk test. This is probably an overrepresentation of the patient. So this is an exercise physiologist at the Brigham who's doing the testing. But a lot of our patients tolerate this pretty well, and I'll show you some data. Marjorie and the team can attest to this. So we perform it at the initial diagnostic workup, and subsequently we track and we monitor our treatment response. And the protocol is as such that you get baseline spirometry, 2 minutes resting variables, and then you do 3 minutes of stepping. And then we get recovery data after. And the data set that you get here are very similar, if not exactly similar, to what you get in the conventional CPAP. But the difference is that it's more germane to our patient population, right? Those with lung disease, those with pulmonary hypertension, those with contracture deformities, connective tissue disease, all of which cannot give you a maximal effort on conventional CPAP. And so for our patient population, giving a submaximum CPAP effort will be suffice. And we've looked at this because we get a lot of cardiology referrals, and they want us to do a right heart to rule out pulmonary hypertension. So we looked at our own data set to see if the CPAP done in an outpatient setting, whether it can differentiate between different HFpEF phenotypes. And so these are the variables that you get. So you get this a variable called GX gap, is essentially the product of the end-tidal CO2 and the O2 pulse, the ventilatory efficiency, the oxygen uptake efficiency slope, and the change in the end-tidal CO2. And what these variables tells us is that the more severe the derangements, the more likely you are to have combined pre- and post-capillary pulmonary hypertension. So in essence, the aberrant submaximum CPAP variables demonstrates the presence of pre-capillary pulmonary vasculature or pulmonary vascular disease. And you can see here that all these variables significantly are worse in patients with combined pre- and post-capillary pulmonary hypertension. And so when we do this testing and we find that the echoes demonstrates pulmonary hypertension, but yet a lot of the burden of pulmonary vascular disease, all these variables are not drastically abnormal, we will tell them, look, this is left-sided disease. There's limited utility in pursuing a right heart catheterization, so you avoid an invasive procedure in this patient population. We then took it a step further because now we know that there's an FDA-approved treatment for patients with pulmonary hypertension and lung disease, which is inhaled treprostinil. And we also wanted to help our ILD colleagues out. And we found that the submax parameters also actually help distinguish the presence of pulmonary hypertension in patients with interstitial lung disease and those with ILD without pulmonary hypertension. So you can see here again all these variables here in patients with pulmonary hypertension and ILD have more significant decrement in the submaximum CPAP variables. And on the receiver operating curve, the GX gap value, it provides a better discriminant between non-PH-ILD and PH-ILD, but the sensitivity was still lacking. And so what we then did was we did a decision tree analysis, we did a CART analysis, and the area under the curve was 0.94 with a sensitivity of 93% and a specificity of 86%. So if you have someone with PH-ILD and you follow this algorithm, so if you have an abnormal GX cap with an elevated RBSP, that gives you a probability of PH-ILD of 100%. Now, the caveat is that the echoes are very unreliable in PH-ILD, and so even in that setting, if you omit the echo data, you still get a pretty high probability of determining whether someone has PH in ILD. And so in these patients, then we proceed to do a right heart catheterization, and now there's established therapy for PH-ILD, we can initiate treatment beyond pirfenidone and the other drug. So the RVs the RV function is a very important prognostic marker in pulmonary hypertension. It's important across different pH phenotypes. So in acute PEs, it's significant, and in various different chronic pulmonary hypertension as well. So in PAH, in patients with HFpEF, and in patients with CTEPH. The problem is the current reference standard that we use have limitations. So cardiac MRI, it's either too complex, too expensive. The echo has limited value in RV functional assessment, and they're very difficult to reproduce at bedside, particularly in the critical care setting when patients are supine on the ventilator. It's very difficult to give a good assessment of the right ventricle. The reference standard here is the multi-beat pressure volume relationship. So it's very complex, it's expensive, you can't apply it at the bedside. And the idea is that you generate a series of pressure volume loops by altering the preload. So by Valsalva, or you inflate the balloon in the inferior vena cava to alter the preload. And from that, at the end systolic pressure volume relationship, you draw a slope, you get a measure of contractile function. At the end diastolic pressure volume relationship, you draw a slope and you get the function of the diastolic property of the RV chamber. And from that, you can get a whole host of information, the contractile function. You can get the sum measure afterload. You can get the coupling of the ventricle to the pulmonary circulation. You can get the stiffness constant. You can get the stroke work, which is the area under the loop. You can get the potential energy and the pressure volume area. This is designed to confuse you, so that's why it's up there. And Paul Hurd, who's the loop wizard, is the one who's supplying me with this curve. So we decided to then apply the variables that you get from the pressure volume. Can we get those variables just from a standard right heart catheterization? And so the red curve right here is the RV pressure curve, and these black peaks right here, that's the pressure derivative of the RV pressure. And if you were to square the pressure derivative, you get 4 peaks, and each of these 4 peaks, they coincide with a specific event in the cardiac cycle. For example, the third peak here is the end systolic pressure. And that's very important, because that forms the basis of determining right ventricular contractile function, which I'll explain in a second. And so we came up with a method to not only estimate RV-PA coupling, but also estimate right ventricular ejection fraction solely from the pressure waveform by knowing what the end systolic pressure is and what the Pmax is. The Pmax is the theoretical pressure that the RV generates in an isovolemic beat. We compared that to the reference standard method, which is the RV ejection fraction, and it showed very strong correlation. We also showed that this is a separate study where we applied it at the bedside once again with the RV ejection fraction, and it correlates strongly with the measured RVEF, particularly in those who have RV failure. And this is an example during our CPAT in a patient where we're tracking the ejection fraction on this software, and you can see the EF begins to decline as the RV ejection fraction is the one below here. That's the right ventricular pressure waveform, and the RV EF begins to decline as the patient approaches maximal effort. We also leverage the RV pressure waveform during our clinical right heart cath to get a much more comprehensive assessment of RV afterload. So the conventional measure of RV afterload is the pulmonary vascular resistance. It's easy to get right. It's easy to measure during the cardiac catheterization, but it's an incomplete representation of the RV afterload. It doesn't take into account the pulsatile component of the RV afterload. Because what's important under the RV, it's an interaction between compliance, resistance, and wave reflection. And so all of those measures that I just mentioned is encompassed in this measure called pulmonary vascular impedance. The problem with impedance and wave reflection, it's a very complex measure. You have to use spectral analysis with simultaneous pressure and flow assessment. But we found we validated this method where we can estimate during our clinical right heart catheterization pulmonary vascular impedance and waveform reflection. So this allows us to extend beyond just the conventional means of pulmonary vascular resistance, which is not only a static measure of afterload, but also a late manifestation of pulmonary vascular disease at rest. So we'll focus a little bit more on the RV and dynamically during exercise, what we've done and what it has informed us. So this is a slide that demonstrates the setup of the level 3. So we tend to place a 5-port swan, so we get continuous RA, RV, PA, and every minute we wedge. We have a metabolic cart that allows for gas exchange analysis, including VO2 assessment. We have an arterial line that we draw blood gas every minute so we can get the arterial O2 content, and we draw a mixed venous gas as well every minute so we can get the venous O2 content. And from that, you can actually get the direct Fick cardiac output because you can solve for the Fick equation. You can get oxygen extraction because you know what the arterial and venous O2 content difference, and then you can get more advanced hemodynamic assessments like the PVR and compliance. So this is our setup here at Yale. We do it upright and we do it semi-recumbent if we need simultaneous echocardiogram. So we get continuous monitoring of the RVPA, RA pressures. Every minute we get a wedge. And then we also draw an arterial blood gas and a venous blood gas that gets sent to the lab for analysis. And this particular patient, we do it in a semi-recumbent bite that tilts so it opens up the LV apex. And this particular patient, we were looking to see the dynamic worsening of his MR. So he had moderate MR at rest, and we wanted to see if the moderate MR becomes severe and it contributes to his central hemodynamics and his decrement in exercise capacity. And so using invasive CPAT, we've been able to highlight a couple of things. The first one is that it allows for the earlier diagnosis of pulmonary hypertension, where we measure this variable called distensibility. Distensibility is the change in vessel diameter for a given change of pressure, and it can only be measured during incremental exercise testing. And we compare it to all conventional hemodynamic means, so resting, peak exercise, pulmonary vascular resistance, compliance, and we found that pulmonary vascular distensibility was the best hemodynamic measure that allowed for latent or early diagnosis of pulmonary vascular disease. We demonstrated that the right ventricle behaves very differently in different forms of HFpEF phenotype. So if you have an increase in PVR, your right ventricle tends to behave a lot more like patients with pulmonary arterial hypertension. We found that patients with exercise pulmonary hypertension, which is an early form of pulmonary hypertension, so patients have normal resting hemodynamics but develop pulmonary hypertension with exercise, we found that the right ventricle dynamically uncouples or dynamically the contractile function reduces during exercise, even in the absence of resting hemodynamic abnormality. We demonstrated there's a sex differences in how the right ventricle responds during HFpEF. So the male and female HFpEF patients both increase their afterload with exercise, but the female HFpEF patients are able to augment the contractile function of the right ventricle, while the males don't. And as a result, their peak VO2 is higher in the female population. We looked at the dynamic response of the right ventricle across different pulmonary hypertension spectrum. And the idea behind it is to determine at which point the right ventricle uncouples from the pulmonary circulation. The idea behind this, can we individualize exercise prescription to the particular patient? So I'll show you an example here. So on the x-axis, there's two measures of right ventricular contractile function. One is coupling and one is ejection fraction. And we look at once they reach the anaerobic threshold at minute 3, the right ventricle function decreases. So the idea here, maybe in this particular patient, you devise an exercise regimen or prescription where you avoid minutes 4 and minutes 5 and just focus on not causing RV ischemia and RV dysfunction. And we're going to shift gears a little bit away from pulmonary hypertension and focus on the utility of CPAP in long COVID. And so this is our first study where we looked at our first study, and actually the first study that described the aberrant exercise pathophysiology in patients with long COVID. So these are patients who, it was a small study, there were 10 patients over a year after acute COVID, mild self-limiting COVID, who had normal echoes, normal conventional investigative testing, so CTs, PFTs, level 1 CPAPs, normal, who we subjected to a level 3 CPAP. And what we found was that their excess capacity is reduced relative to controls, and not because there was a central cardiac limit. These folks didn't have any heart failure or pulmonary hypertension, but the limitation was peripheral. There was an impaired ability of tissue oxygen extraction at the capillary level in these folks. And additionally, these folks also demonstrated an exaggerated hyperventilatory response during exercise with an appropriate decrement in dead space. So the ventilatory inefficiency that you see here is not because of dead space ventilation, but it's because of an exaggerated hyperventilatory response, which we don't know quite why they hyperventilate during exercise. We followed it up with the larger series here at Yale. It's about 55 patients, and I just wanted to highlight that again, these are patients over a year after their acute COVID illness, and when we looked at those who did undergo supervised rehab versus those who did not undergo supervised rehab, there was no difference in the extraction. Because when we first published our first paper, a lot of folks said that these folks were deconditioned, but they're not. So these are folks who actually underwent supervised rehab and yet still had an impediment in their tissue oxygen extraction. Oh, and by showing you what we've done more recently, how we've integrated omics to better understand why these patients have the abnormal exercise physiology. So the first study we did was a proteomic one. This was a grant we got from the Chest and ETS. And what we found was that there was a dichotomy in the physiology expressed as well as the protein expressed at peak exercise in patients with long COVID. So DO2 represents oxygen delivery, and you can see those with milder impairment in oxygen extraction, they had greater oxygen delivery. It's reflecting a compensatory central cardiac response to increased tissue oxygen delivery in response to the impaired tissue oxygenation peripherally. We also found there was a dichotomy in the protein being expressed between the two groups. So in the ones that are had mild impairment of tissue oxygen extraction, they actually had upregulation of proteins involved in mitochondrial oxidative phosphorylation. Again, it appears to be that there's this compensatory proteomic mechanism trying to extract the oxygen and deliver to it. Whereas in the most severely affected group, you get proteins upregulated that are involved in inflammation and endotheliopathy. This is just to recap the different pathways involved in energy production during exercise. So you have aerobic energy metabolism, where fatty acid, glucose, and amino acid oxidation takes precedence, and you have anaerobic energy metabolism where you see glycogen, phosphocreatine, and pure nucleotide take precedence. So the other study that we did, this was, I can't remember which grant this was now. Someone paid for it, but we did metabolomic analysis, this time looking at changes in the arterial and venous expression of metabolites from rest to peak exercise. This was just published last week, actually. So look at this particular graph. METs is the metabolic equivalence of a particular activity. So and then on the y-axis, the change in the tissue oxygen extraction. If you look at about 4 METs, the extraction begins to plateau. So 4 METs is equivalent to carrying out household chores or just going up a flight of stairs. So at that low level of exercise intensity, you begin to see that extraction begins to plateau. There's a limit in tissue oxygen extraction, suggesting that beyond 4 METs, now you have anaerobic metabolism has to take place because tissue oxygen extraction is impaired. And the first graph is a heat map. We looked at the different metabolites that were expressed, and there was no difference in the expression between COVID severity, age, sex, and BMI. These two are the targeted individual metabolites. And what we found first was there was a net consumption of inosine during exercise, as reflected by the increase in the arteriovenous difference in inosine. And as I described in a couple of slides earlier, inosine actually plays a very important role in the purine nucleotide anaerobic ATP generation pathway. So it may be that beyond 4 METs, this is the pathway that predominates in these patients. We also found that peak venous succinate, which is we found that it correlated with peak VO2, suggesting that it may have a role as a biomarker for long COVID. Succinate release also occurs, by the activity of succinate dehydrogenase, which is active primarily in hypoxic conditions. Level 3s, catheters, too complex, too invasive, giving Dr. Joseph too much time in the cath lab. Do we have alternatives to this, right? So this was a grant. This was This is a YCCI grant, I think. Yeah. So this is the physics department helped me build this contraption. So I'll show you this. So the idea is that the magnet. So this is an MR spectroscopy single limb exercise. This is my attempt at drawing someone's limb. So this is the thigh. That's the magnet right there. And then there's a exercise band that you flex and extend, your leg to. And this is an example of the exercise MR spectroscopy looking at the decline and recovery of phosphocreatinine. We talked about how phosphocreatinine is important in anaerobic energy metabolism. So you can see at rest to exercise, there's a decline in muscle phosphocreatinine, and then when recovery, it recovers. And we hypothesize that the rapid rate of decline and slower recovery that is seen in long COVID is associated with reduced exercise capacity and bad oxygen extraction. This is an example. The patient obviously goes into the magnet, but I couldn't stand in there and take the video of people in the magnet. So this is what they do. So the magnet sits on the thigh and they flex and extend their knee to the resistance band. And anyway, so you can see that this is a subject who had acute COVID but no long COVID symptoms, and this is a patient with long COVID, and you can see that the patient with long COVID had a lower recovery in the phosphocreatinine. So the study is still ongoing right now. The other thing that we found in this is that when we repeated the study, so the patient would get the study done, we get this first set of data, and then they rested for 20 minutes and then repeated the study. The phosphocreatinine levels actually begin at a lower level, so they actually have depleted phosphocreatinine even after a sustained resting period as well. And the degree of recovery is worse than the first time around. And so that phenomenon clinically is known as post-exertional malaise, which is almost a pathognomonic phenomenon in patients with long COVID. So in conclusion, dynamic assessment during exercise can help identify different cardiopulmonary response across different stages of diseases and across different spectrums, and may also help inform exercise prescriptions. The information that we gather from RV pressure waveform allows for a much more comprehensive bedside assessment of right ventricular function. And if you can integrate omics to this aberrant exercise pathophysiology, you can not only elucidate the exact cause, but hopefully also direct treatment towards these abnormal molecular and pathophysiology findings. So these are the people that helped me in my clinical work and my research work. Aaron Waxman, as you all know, I taught him everything he knows. These are the folks in the physics lab that helped me with the MR spectroscopy study. This is my pulmonary vascular team. It's the invasive CPAP they met here. But I'm happy to take questions.
Okay, thanks, Cindy, for a great talk. I'll get started. So it seems like in a lot of the data in the long COVID patients, you're showing impaired peripheral oxygen extraction. And there was some thought initially, or at least partially, that some peripheral shunting process. But from some of the later data, it seems like you may be showing that it's more of a myopathic process. Is it one? Is it both? What do you think?
Yeah, so the generalized term is a mismatch between microcirculatory perfusion and mitochondrial oxidative metabolism. In the ME/CFS patients, the chronic fatigue syndrome patients, there's data to show that there might be some microcirculatory shunting, but in the long COVID patients, it seems to be that a lot of the evidence that we have right now are showing there's a reduction in enzymatic activity involved in mitochondrial oxidative phosphorylation. The innocent thing is not new. Actually, there was a paper in Nature that showed that there was on muscle biopsy they have reduced innocent content at rest. And they also did on the muscle biopsy, they also looked at enzymes involved in mitochondrial oxidative phosphorylation, and the enzymatic activity was reduced. One of them is citric synthase. We actually have. I was going to backtrack. This finding of the findings that I did describe to you are not novel. We've been doing level 3 CPATs predating COVID, and these are the abnormal findings that we find in these patients. In fact, the group at the Brigham, in their chronic fatigue syndrome patients, they had sent 13 or 15 muscle biopsies down to the lab at Baylor that does this analysis, and can't remember what it is, 11 out of 13 or 13 out of 15 of those muscle biopsies all had evidence of reduction in citric synthase enzymatic activity. The question is, what do we do about it? And we don't have any medications right now that stoke mitochondrial function. But at last, it gives us that information for the patients to tell them, look, there's a abnormal pathophysiology that's accounting for symptoms, and it's not in your head. So, which is just as important, I feel.
Thank you, Indy. That was fascinating. I wanted to go back to your comment about the pulmonary vascular distensibility. And I'm going to take a wild guess that it's even more complicated than the simple measure, right?
Yeah.
Because I'm thinking about what we know is going on with the pulmonary vessels in some of these disease states where you're getting all the intimal proliferation and clotting, and then you're recruiting otherwise normal vessels, which are now becoming dilated, and presumably their pressure relationships are changing, as opposed to everything having some sort of uniform change in their distensibility. So how are you thinking about this? What does the change in distensibility actually reflect?
Yeah, so backtrack. So with exercise, your pulmonary vascular resistance decreases, right? And the reason why it decreases is because you begin to recruit and distend your vasculature. So you recruit first as your cardiac output increases, you recruit, and then you distend your vasculature. And so the distensibility that we measure obviously occurs after the recruitment. So you begin to recruit, and then if you have small vessel disease, remodel vasculature, your distensibility is limited. You're not going to distend any more than say I would or you would. And so that's why it captures. It captures small vessel disease dynamically during exercise. The calculation is, it takes into account various pressure flow measures, so cardiac output, wedge, and total pulmonary resistance, and it's done at every stage of exercise. It's actually a slope that you derive of it. So it captures disease of the small vessels, where the anticipation in a normal pulmonary circulation, it's meant to distend to a certain extent, and the normal value is up there. But if you don't reach that level of distensibility, that indicates that that vessel is diseased. There's now actually an online calculator similar to MetCalc that I think Rebecca Vanderpool from Ohio State created. So that's accessible to everyone to use, but they have to have a level 3 setup.
Thank you.
Sebastian.
Thank you. Now, I do take note that some of these patients had a heightened ventilatory response, and often we do see patients in clinic who have this sense of urge. I cannot take a deep breath, even when I sit on a couch without doing exercise, which clearly points towards like a controller problem of the respiratory system.
Yeah.
So I wonder if that could be connected. And the second question is probably highly speculative when you think about oxygen sensing mechanism.
Yeah.
It's like, similar biochemistry, what you've described with cytochromes and so forth and phosphorylations. Do you think that these alterations you see in the muscle metabolism in terms of oxygen uptake could actually also play a role in interference with oxygen sensing, leading to that phenotype of hyperventilation?
Yeah, it's a holy grail in exercise physiology as to what, so if you look at a normal response, right, with exercise, your CO2 actually remains stable until, of course, you reach the latter stage of exercises. What drives that ventilation, we don't know. There's a suggestion that it's a byproduct of muscle metabolism, and Phil can attest to this. They were trying to they put this large blood pressure cuffs that go off during exercise, and then they rapidly deflate. And the idea is that can they catch these abnormal muscle metabolites? Of course, it didn't work because you're subjecting someone to maximal exercise and then you suddenly inflate the cuff. So that's one reasoning. Could it be abnormal byproducts of muscle metabolism that drives the hyperventilation? In our first chest paper, the review actually suggested it. The reviewer was Evelyn Horn at Cornell. She suggested that could it be because a lot of these long COVID patients on muscle biopsies had muscle atrophy, muscle necrosis, even though in mild COVID, could there be an abnormal muscle ergometer response? So whether there's an abnormal, just like heart failure patients, they have a hyperventilatory response too with exercise. And in heart failure, they think it's because the muscle senses the central system to increase their ventilation abnormally. So it could be either one of those, but we don't know.
Okay, Sandy?
Thanks, Indy. So I was wondering if you could talk a little bit about treatment, like how your level 3 CPAPs impact treatment. We didn't really talk about treatment with folks. I mean, I assume if you diagnose PH earlier, exercise-induced PH, maybe you're putting them on agents sooner. Thinking about the long COVID patients, I know you end up putting some of those folks on Mestinon. Is there a role for like empiric Mestinon without doing level 3? And then finally, like you talked about different exercise regimens that you could prescribe for people. Have you guys done that? And like, what have you seen? Like, how does this alter what you do?
Yeah. So for exercise pulmonary hypertension, we treat them in monotherapy, and it's still not in the guidelines. Exercise pulmonary hypertension, the hemodynamic criteria is in the guidelines, but the treatment isn't. But nonetheless, we treat them, and patients do feel better, objectively and subjectively. The second question is, what do we do with the long COVID patients? Phil actually did a randomized placebo-controlled trial using Mestinon, acute dose Mestinon, in patients with chronic fatigue syndrome. And what they found was, so they subjected them to a level 3 CPAP, and then one group got placebo and the other one got the acute dose Mestinon, and they repeated the CPAP 45 minutes to an hour later. And what they found was that the placebo group had a worsening in the exercise capacity, but the acute Mestinon group did not. What the long-term effects of Mestinon, we don't know. Anecdotally, it's hit and miss in this patient population. We tried, some patients respond, others don't. We don't know why. More recently, there's evidence of using ultra-low dose naltrexone in this patient population. The theory behind that is that it's one of two things. It regulates T cell function, so it reduces the pro-inflammatory cytokines. It regulates B cells, so it mitigates the autoantibody response in these folks as well. It's been shown to be helpful in POTS, but no, there's no definitive treatment in this long COVID patients. The third question about exercise. When we had all these papers out, I can't remember, was it the Post or the Atlantic that interviewed us, and they really wanted something they really wanted to highlight the agenda. And the agenda was like, exercise is toxic and exercise is dangerous. So why are you subjecting them to exercise? And because of this post-exertional malaise phenomenon. And I do agree, like, you shouldn't subject, the patients shouldn't be subjected to a certain to an exercise regimen where they would then be bedbound for 24 to 48 hours later. Having said that, I don't know of a single chronic disease state where exercise is not beneficial. And so what we do is that we work with Kathy, who's the PT in our clinic, where we come up with a protocol called which is adopted for patients with POTS, called the Levine or Dallas protocol. It's a graded exercise regimen. So you start off very, very mild exercise, like, mild yoga, mild Pilates, and then you start building it up to what you can. So that's the regimen we do. Some patients, it really depends where you start off, right? So, for example, we had a professional MMA fighter. He's not going to start with low level activity. So Kathy then works with them and decides, what level they should start at, and then build up from there. So some patients have found that beneficial as well.
Indeed.
Yeah.
I have another exercise-related question or comment. So in COPD, for example, it's well established that the presence of skeletal muscle dysfunction underlies a significant part of why exercise training improves people's exercise tolerance, dyspnea, quality of life, and so on. There's also been some demonstrated peripheral muscle dysfunction, skeletal muscle dysfunction in people with various forms of pulmonary hypertension, particularly PAH. And I'm wondering, what isn't studied well at all yet? And I'm thinking that your, level 3 CPETs are a golden opportunity to do so, is to really understand more about the skeletal muscle dysfunction in people with different forms of pulmonary hypertension, and secondarily, their response to exercise training, because that's a big open hole in the field right now. And another aspect, believe it or not, out of all the randomized controlled trials, while there's good evidence for pulmonary rehabilitation and pulmonary hypertension, as you know, not one of those randomized controlled trials has looked at dyspnea, if you can believe it, not one. So I would advocate there's a lot of opportunity here to partner and to do some of that stuff. Happy to chat about it if you want.
Just pointing at Marjorie.
Okay, so we have a few questions from Dr. Mathey in the chat. So I'll start with the last one, actually. Are you treating patients with sole impaired distensibility?
Yeah, so a lot of times, there's actually evidence to do that. So Greg Lewis's group at the MGH looked at distensibility in patients with HFpEF and treated them with sildenafil, and actually showed that there was improvement in distensibility and functional outcomes following treatment with sildenafil monotherapy. Now, the distensibility, if you have an abnormal distensibility, you would have exercise pulmonary hypertension. You typically meet the criteria for exercise pulmonary hypertension, and so we treat them. Yes, we do.
Right, we have a question from Sherwin.
Okay, indeed. How are you doing? It was amazing. It was really great. I'm gonna go through the papers and we'll have a lot more conversation. But one thing I wanted to make sure I understood correctly. You brought up the concept of impedance. That is for the ventricle or the vasculature?
For the vasculature.
For the vasculature.
Yeah, it's a measure of
That's what I thought.
proximal compliance of the proximal pulmonary arterial compliance impedances.
Okay, so and then you in answer to the question you said maybe that's because of opening up new recruitment. So impedance has two things in it. It has resistance and reactance, as you well know.
Yeah.
Do you think that there is a progression from like lack of reactive, like when the vessels cannot extend to remodeling when the reactance is gone and just resistance is up? Like, do you see that between exercise and let's say established pulmonary hypertension? Like first in exercise, you have that reactance for a part. You have like meaning vessels can extend but can go back. They still go back and forth, and then they get fixed with high resistance.
We haven't looked at our impedance measures during exercise, or don't know the answer to that.
Just because that may the physiological thing. The second thing with this is simpler. How is for the COVID, for the long COVID? It's like paradoxical relax on PRDX3 or coenzyme Q or any of those things.
Yeah.
Tried or what happened?
We've tried those. We call them a mitochondrial cocktail.
What happened? Yeah. Nothing.
Indy, so just
Lou,
one.
wait 1 second, we gotta do it, the microphones, so they can hear.
Indy, great talk. Thanks so much for sharing all the work that you've been doing. I'm curious about kind of moving on from long COVID and thinking about just post-ICU syndrome. I know long COVID includes some patients that were in the ICU and some that weren't, but have you looked at any of these exercise tolerance parameters to explain the musculoskeletal dysfunction that people with post-ICU syndrome experience?
We had not, but we haven't got referrals for it. But the abnormal physiology that I just described to you, we see it in post-COVID, obviously, other post-infectious disease process, post-viral syndromes, flu, RSV, post-Lyme, and autoimmune disease processes as well. So I actually had a patient who has bullous pemphigoid, who had this similar long COVID exercise physiology. And she was seeing myself, rheumatology, for some reason, neurology, who did a muscle biopsy and sent it to the lab in Baylor. And the muscle biopsy came back normal. And I just took the opportunity to get the form and tick off the mitochondrial enzymes, you know, and it came back with citrate synthase deficiency, similar to the long COVID patient. But then I don't know what to do with it, so.
Yeah.
There was one more question from the chat from Dr. Mathe is, are you seeing peripheral oxygen extraction improve in the long COVID patients with time?
You know, there's a patient that is from Arizona who came to see us. He didn't know if he had COVID. He had post-viral syndrome, and we did the level 3 and it showed this abnormal finding. And he wanted some form of treatment. We told him our anecdotal experience with methadone and low dose naltrexone, and he opted for the low dose naltrexone. And this is N of 1. He feels back to baseline. The only side effect he said he has was he's been having sleep disturbances where he'd wake up and smack his wife. But otherwise, he says like he's back to baseline, and so much so that he's actually willing to come back for a second level 3 CPAP just to see what that does to his tissue oxygen extraction. So I'll let you know.
All right, everyone, thanks very much for your time.